know me by now, but my name is Keisha Jackson. Today I'll be lecturing about complications that women experience more in their second and third trimester of pregnancy. When I initially chose this topic, it was more because we get a lot of experience in first trimester complications. But I have to say, with my current state, just reviewing this, it wasn't very reassuring. But I'm just happy that I haven't had any of these personal experiences yet. Today is 36 weeks and 6 days. So tomorrow I'm full term. So in case you're working with me the next 2 weeks and all of a sudden I just grab my belly and leave, you know what happened. Okay? The second and third trimester of pregnancy is a period of extensive physical growth and maturation of the fetus. The majority of these complications that we're going to be discussing is more for review, because that's one of the things I love about obstetrics, is that it's somewhat straightforward, and in terms of just, if you save the mother, yes, you're most likely going to save the baby, but also you do have to reach out for help as needed, especially when we talk about abruption and things like later on. Even though it's a period of rapid growth, it's also a period that does have complications that can be life-threatening for the mother and the baby.
Cool.
Today I'm going to be talking about just doing some general definitions of the pregnancy stages, the 20-week protocol that's in existence as a majority of EDs, pregnancy physiology, some complications, and if time persists, just a brief discussion of resuscitation in pregnancy. So just to review the definitions, and again, you guys know all of this. First trimester is usually characterized as 1 week to 13 weeks. It's when the baby's body structure and organ systems develop. It's also what we see most often in the ED. Most miscarriages occur during that period, and most also birth defects. You'll also have those patients that come in with the typical symptoms of nausea, fatigue, vomiting, breast tenderness, frequent urination. That's what's going to present. The second trimester, which is usually the 14 weeks to 26 weeks, is a golden period, and I have to say that is true, because many of the unpleasant feelings of the first trimester resolve in second trimester. If you're one of those people that it goes through the whole time, that just sucks. Especially since in the third trimester, at home stretch, we develop new symptoms which are just as wonderful. Third trimester is usually 27 weeks to, technically it's supposed to go to 42, but you know, pregnancy normal goes to 40 weeks, which is 10 months, not 9 months. It's 10 months. Symptoms that you'll experience are shortness of breath, hemorrhoids, urinary incontinence, varicose veins, sleeping problems, and all because that wonderful uterus that's bringing that life goes from being like 2 ounces to almost 3 pounds in such a rapid period of time. But hey, it's a beautiful thing, right? It's life. But in EM, actually, we rarely look at pregnancy as just the 3 trimesters, but more look at it as halves. At county and many other institutions, there is protocol that determines what happens to patients when they're less than 20 weeks of gestation or more than 20 weeks of gestation. A specific protocol actually exists in Kings County. I believe also for downstate, but I'm not completely sure, that will tell you what we're going to do for the patients. And I'm actually just going to remind you of it, even though the majority of times it's not going to be you guys' decision. It's either going to be done by the nurse or the attendant. So the first major statement: all patients presented to the ED pregnant with 20 weeks of gestation found to be in active labor without any other emergent medical needs will be transported to the obstetrics department by stretcher, accompanied by an ED nurse. These patients will not require triage or registration in the ED. Majority of times, you won't even know they come in. To be honest, and most OBGYNs are very good in their instructions with their patients, that they tell them, just come upstairs to labor and delivery. That's what mine tell me, and that's what I've done for the prior 2. But sometimes patients will just still present to the ED. Next statement. All patients presenting to the ED pregnant with 20 weeks or greater gestation with minor injuries and without concern of injury to the fetus can be treated and released from the ED. This is actually where we need to do better. And it's not by you guys itself, Usually these patients who are complaining, they come in like, my foot hurts, and triage sends them upstairs. And then they do whatever they need to do, whatever they, just watching them, and then they send them back downstairs for their foot. So the physicians are usually not involved in determining this. It's more of a nursing thing, but if a patient comes in for something absolutely not related to the baby, they do not have to be seen by obstetrics, despite being 20 weeks or more. Now, this is probably the most relevant to us. All patients presented to the ED pregnant with 20 weeks or greater in which the ED attendant determines that the patient's medical condition requires stabilization in the ED and immediate consultation with OBT will occur. To be honest, this is a protocol, even though it's been in effect for years, but it came about because there was some issues in getting in contact with OB. There's actually, and in the second portion of this protocol that's actually found on SharePoint, we are instructed to not only page overhead, to call labor and delivery, and we're changing all that because we're not going to go through all of that. One call, they need to come, and that's what shouldn't matter. But there was unfortunately a bad outcome in getting them to respond to the ED, which resulted in something being put in writing, which is not always the most beneficial. So it's important for us, as we move along, it's important that we understand the basic physiological changes that occur with pregnancy. Oh, sorry, go ahead.
Sorry, no, when it says 20 weeks, there's been some cases where there's been arguments on, is it by dates, is it by last ultrasound, what is the determination of 20 weeks?
It's whatever the patient can actually determine, okay? So if someone there's some patient that could clearly say by their last menstrual period, and we tend to go more by last menstrual period, that's what's people are more commonly know, even though they might know, oh, even I've had my ultrasound, I don't remember what the ultrasound said, I know from my last menstrual period what my dates are. But whatever the patient can say reliably, this is what is accurate, then we go by that.
And if there's a situation where they say the 20 weeks and the ultrasound says less, and the upstairs...
And upstairs will send them downstairs.
Yeah.
Yes, that happens. Go by the patient's complaint. Because if it's something that has nothing to do with the baby, then what's wrong with them sending the patient back downstairs? If it's something that is actually involved in the belly, and to be honest, yes, now they're 19, I had a patient that was 19 weeks and 6 days. It's like, okay, you're gonna see the patient in the ER. That's all, I'm just gonna do a consult. Might be kind of passive aggressive, but that's what I did in that case. So like I was saying, we have to understand the basic physiological changes that happen with pregnancy. Some of us will not be practicing in a place with 24/7 obstetrics, and it's just important to just know what's okay, that's the basic changes that are going to happen with a normal pregnancy. I know this is very hard to see, so I'm just going to summarize it and just give you a brief overview. So, and we'll go through by organ system. Cardiovascular system, there's going to be an increase in the cardiac output, decrease in the peripheral resistance, decrease in blood pressure in the first trimester and early second trimester, which will eventually return to normal by the end of the second trimester. And there's also an increase in plasma volume and CVP. Hematologic changes includes increase in multiple coagulation factors that results in an increase in risk of thromboembolism, which we all know. They're pregnant, they can definitely get a clot. Respiratory changes, there'll be an elevation of the diaphragm, increase in tidal volume and minute ventilation. Dactylate phosphate will also increase, which actually puts the pregnant patient at risk for cholecystitis and cholelithiasis. And other GI changes include decreased lower esophageal tone and gastric emptying, which gives a wonderful feeling at night of reflux disease. It's great. And that's basically the important ones. So the complications that I'm going to discuss I want to just use very common chief complaints that we see every day in the ED, like I'm here because my blood pressure is elevated, the vaginal bleeder, shortened breast or chest discomfort. But we're going to tailor it towards, again, it's the patient in the second and third trimester and how we're going to expand our differential with these patients. So elevated blood pressure in pregnancy. As this as I stated earlier, there's a decrease in systemic vascular resistance that results in a decrease in maternal blood pressure. So blood pressure basically reaches all-time low in the end of the first trimester, the beginning of the second trimester, but then it's going to return to the pre-pregnancy values near the end of the second trimester. However, hypertension is still a common finding, and there's various classifications that exist. There's chronic hypertension, which is self-explanatory, pre-existing patient that always had hypertension, they were prior to pregnancy, or before 20 weeks, they were hypertensive. For gestational hypertension, it's usually a patient that has a blood pressure that's greater than 140/90, and of course their onset is greater than 20 weeks. Where we're going to focus more is one preeclampsia and eclampsia, and then of course if it's superimposed on chronic hypertension. And this involves, for preeclampsia, there's elevated blood pressure greater than 140/90, and a proteinuria on the dipstick, and of course occurring after 20 weeks. So preeclampsia and eclampsia, it usually complicates 6 to 8% of pregnancies in developed nations. It actually causes 20% of maternal deaths in the US, and it's a major cause of neonatal morbidity and mortality. There are risk factors that will put someone at increased risk. They're one, having a prior history, that's always very important. Family history, diabetes, young or older maternal age, multiple gestations, pre-existing hypertension, chronic kidney diseases, thrombophilias, CVD. The exact etiology of where someone, what causes a preeclampsia or eclampsia is not fully known, but they do believe that it's due from the placental fetal unit. And involves renin-angiotensin system. There's a kinase, FMS, tyrosine kinase, or prostaglandin abnormalities. For EM, I don't think we need to know the exact cause. We just need to know how to classify, to diagnosis, and how we're going to treat it. So for preeclampsia, we could actually divide it into a mild or severe disease, and that's the typical classification. For mild, the blood pressure is going to be between 140 and 160. For systolic, diastolic will be between 90 and 110. And they prefer to have proteinuria measured on a 24-hour sample, but that's not feasible in the ED. So we're just going to go by our urine dipstick, and if it's +1, you got proteinuria, and you're good enough. But technically, proteinuria between 3 grams and 5 grams on a 24-hour sample is mild. When you look at severe, you're going to have systolic blood pressure greater than 160, diastolic greater than 110, and proteinuria greater than 5 grams. Signs and symptoms are headache, visual disturbances, they're going to have pain either in the right upper quadrant or the epigastric area, they're going to have decreased urination, petechiae due to most likely the thrombocytopenia, they're going to feel like, oh, my belly's not as big as it was before, shortness of breath, and even some of them can actually have some chest pain. Eclampsia, which is technically seizures or neurological symptoms in a patient with signs of preeclampsia, can easily occur from preeclampsia. The progression is unpredictable and can happen very rapidly. It usually happens intrapartum or at least 48 hours post-delivery, but that's still something for the ER doctor we have to be concerned about, because they could be discharged from the hospital and come back and have eclampsia. HELP itself is a life-threatening obstetric complication. It's actually a variant of preeclampsia, and the acronym is based on the major symptoms of the syndrome, which is hemolytic anemia, elevated liver enzymes, and low platelet count. So in addition to the typical blood pressure readings that it's important to obtain laboratory data for your diagnosis of preeclampsia and eclampsia. I'm just going to list a few. This just lists a few, but I'm just going to talk about it. You're definitely going to want a CBC. You're going to note the platelets of the CBC for thrombocytopenia, and that's more for HELP. And you're also going to, of course, obtain a peripheral smear. And that's to identify any signs of hemolysis, such as cystocytes and burst cells. You're going to look at the VUN and creatinine to identify severe disease or end organ damage. You're going to obtain comprehensive to look at liver enzymes for, again, evaluation, once again, for HELP. Like I said before, the protein in the urine We won't have time for a 24-hour collection, so we'll most likely go for a urine dipstick, and it's going to be 1+. That actually calculates out to 30 milligrams per deciliter for protein, but that's all you need. You're going to look at the uric acid. You're going to consider that, because that may be elevated levels can suggest superimposed preeclampsia on chronic hypertension. And then just in general, if a patient is you're considering giving magnesium, it's good to get a magnesium level baseline. Okay?
And then don't they like fibrinogen too?
You could get the coags just in general, and fibrinogen just to evaluate for possible DIC. That is true. So in terms for management, any patient who presents with a hypertensive disorder of pregnancy, your treatment is going to be guided by the degree of the blood pressure elevation, if there's any signs of symptoms of organ damage, dysfunction, anything that you note on lab, and of course if there's any presence of preeclampsia or eclampsia. So chronic hypertension, you could actually just manage the blood pressure if you choose to treat. Obstetric consult is not actually required, and you could discharge patient with close follow-up. For gestational hypertension, it's again defined as a blood pressure above 140/90. There should be no proteinuria. Lab results should be normal. Physical exam completely normal. It's just that their blood pressure is elevated. Now, again, obstetric consult is not required, and you can discharge with follow-up. When you go to mild preeclampsia, that's when you're going to definitely get an obstetric consult. You're going to use the same meds that you would normally use with chronic or with gestational hypertension. Hydralazine and labetalol are preferred. You could do that IV. Or if you want to do something PO, you could do hydralazine PO, labetalol PO, or add nifedipine. With someone in mild preeclampsia, I would definitely recommend getting obstetric consult, but admission is not always required. You can admit for patients to the floor for observation, or you could just also discharge someone with mild preeclampsia with close follow-up. With me, most likely I'll be admitting the patient. Patients with severe preeclampsia and eclampsia going to be most likely, of course, IV medications. Even if they're not eclamptic, you're going to start magnesium. Obstetric consult is definitely required. ICU consult is required because that's where they're going to get admitted. In case the person does seize and they're seizing through after being infused with magnesium, which you know is a loading dose of 4 to 6 grams, followed by maintenance, you would actually try phosphonatoin and actually search for other causes. Do a head CT to rule out bleed, get a finger stick. For help in general, you could actually consider transfusions for these patients. For severe anemia, thrombocytopenia, and steroids itself is controversial. Any questions on preeclampsia or eclampsia? All right. The next wonderful diagnosis that we all love when we see on the whiteboard is the vaginal bleeder. We will love it more when there's an intern in gynecology. So the vaginal bleeding actually complicates 4% of pregnancies in the 3rd trimester. The most common causes and the most serious diagnosis that you have to consider is placental issues. But it can also occur due to infections, lacerations. You're going to take into account recent sexual activity, polyps, and if the patient actually has any kind of bleeding disorder. 2 diagnoses that I will talk about is placental abruption and previa. So abruption is separation of the placenta from the uterine wall. It actually occurs in 1/3 of the vaginal bleeding in patients who are greater than 20 weeks. Risk factors, you most likely know again for your in-service, and you'll definitely need to know for your boards. Prior abruption, trauma, cocaine, tobacco, advanced maternal age, increase in parity. With placental previa, it's implantation of the placenta in the lower uterine segment. It can be characterized as based on the proportion of the cervix that it covers, either complete, partial, marginal, or low-lying. It's a rare cause of bleeding in the 3rd trimester, but it's the most significant cause of bleeding in the 3rd trimester. If someone is bleeding from a previa, they could easily die. Risk factors include C-section, again, advanced maternal age, tobacco, fibroids, and uterine infections. Just so you know, patients might actually present and tell you, oh, in my ultrasound done in my first trimester, I was told that I have a placental previa. However, majority of these that are diagnosed prior to 20 weeks will actually resolve, 90% will resolve by the third trimester. So knowing the history is important, but that doesn't mean that they'll still actually have it in case they come in the third trimester. But of course, hearing that and someone saying I'm bleeding, you're going to consider it. The exact etiology of placental abruption isn't known, but it's, again, you know the risk factors are trauma. So there's increased, they propose there's increased vessel fragility, vascular abnormalities, or just abnormal placental implantation. Signs and symptoms, vaginal bleeding, uterine tenderness, or uterine irritability. And for placental previa, it's just torn vessels at the lower segment, and they're going to come with the painless, bright red vaginal bleeding after, and it usually occurs, and despite it's, again, 20 weeks, usually occurs after the 24th week of gestation. So diagnosis of these, ultrasound is a diagnostic modality of choice. Now when I talked to Kelly this morning, I thought he was going to go through all the details of GYN ultrasound on his lecture, but then he told me he only did torsion this morning. So I apologize, because I didn't go into much detail. But it's, in terms for placental abruption, which you could tell from the first, you're going to see the placenta and you're going to see this basically heterogeneous structure behind the placenta. Just so you know, it's not always, abruption cannot be ruled out using ultrasound. You could use Doppler flow, and here you see this crescent shape here. That is like low echogenicity between the placenta and the uterine wall. And if you put Doppler flow over it, it won't have flow. So it's great to rule in, but you can't rule out an abruption on ultrasound. And with previa, it's you have to be able to, of course, find the placenta and the actual internal os to see the location, how near, if it's covering. Here it looks more like it's low, it's marginal or low lying, and here it's very clear. This is the os, this is the placenta that's covering the opening of the os. So if someone's coming in with bleeding at that time, it's quite easy to tell. Now, what you'll read is that they'll say that you should avoid digital or instrumental probing when you're actually examining these patients that have third trimester bleeding. But still, the best ultrasound is the transvaginal ultrasound, not the transabdominal. So you got to keep that in mind. You're going to do basic labs, and basic labs more in preparation of possible surgery is going to be, yes, your CBC, your comp, but you need your coags and your typing screening, more likely a typing cross. The KB test is really in the emergency room not that valid. Limited utility, you're just going to give that person program no matter what if they're RH negative. So how would we manage the patient with the vaginal bleeding in the third trimester? Of course, you're going to do stabilization, and we focus more on the mother. 2 large bore IVs, fluid resuscitation, and continuous fetal monitoring. You're going to get obstetrics involved. This is an obstetrical emergency. Blood and blood products. ROGAM if they're RH negative, there's no prior prophylaxis, and you're going to consider delivery. You got to consider, is the patient term or near term? Is the mother stable versus unstable? And depending on where they are in pregnancy, are you going to give steroids for possible lung maturity?
Do we have any fetal monitors?
We do. We did. I will take that back. I've seen it. I have seen it. But in cases, like I said, that in that case where you have to bring the OBGYN downstairs to the ER, they actually will bring a nurse and the material, anything that you need for monitoring also, because that has actually been done before. So looking at the patient with shortness of breath and chest discomfort, which again, very common complaint in the ER, but if we're going for the second and third trimester complications, we're going to focus more on peripartum cardiomyopathy. So it's a kind of, what do I say? conundrum in terms of diagnosis, where it's just a criteria for, you have a criteria for the diagnosis, and it's heart failure in the last month of pregnancy or within 5 months of delivery. There is no identifiable cause, there's an absence of recognizable heart disease, and prior to last month, you're going to definitely find signs of left ventricular dysfunction. Etiology is actually unknown, but you could, things that are involved is inflammatory cytokines, myocarditis, abnormal immune response, or familial disease, or gestational hypertension. Risk factors include advanced maternal age, and here it's not the typical 35, it's greater than 30. African descent, multiple fetuses, preeclampsia, eclampsia, or what's it called? Chronic hypertension, cocaine abuse, or long-term tocolytic therapy. So presentation, the patients will complain of shortness of breath, they'll be dyspneic, they'll have cough, chest discomfort, they can have abdominal pain, they can have edema, which is sometimes difficult to recognize as this from a cardiomyopathy, or you're just going to get some edema on pregnancy also. And generalized fatigue, which again, also from just being pregnant and being in your 3rd trimester. But the physical exam findings are included, right? You'll have an elevated or low blood pressure, they'll be tachycardic, you'll have rales, they might have an S3 gallop, distended jugular veins, or have, and you'll see the peripheral edema on the exam. You still have to consider differential, which will include upper or lower respiratory infections, PE, MI, myocarditis, or just typical pregnancy. Just being that far along can actually cause a good amount of these symptoms. When you're working up perpartum cardiomyopathy, your workup is going to do like any other patient that comes in with CHF. You're going to have labs, CBC, cardiac enzymes, chemistry, BNP, chest x-ray to see signs of fluid overload, EKG, which can be very non-specific. You could do a bedside echo, and you could actually see the dilated left ventricle and basically the impairment of the systolic function. So medical therapy is usually supportive in the sense that it's you're optimizing hemodynamics and you're trying to relieve symptoms. Its treatment is similar to other forms of heart failure. You're going to give supplements of oxygen or assisted ventilation as needed. The meds that you would use here, in this case, are nitrites, diuretics, digoxin if needed, and hydralazine, which is more the drug of choice. ACE inhibitors can be used. They're contraindicated before delivery, but once that patient delivers, you can give an ACE. It's okay in terms of for a patient who's breastfeeding. Patients who are refractory to medical therapy, you're definitely going to get cardiology, but intra-aortic balloon pump, you're basically trying any kind of mechanical circulatory support until possible transport, but you have to also consider delivery for these patients. That may resolve symptoms, and also, but these patients, they're at risk of having future CHF postpartum. So I'm just going to end with resuscitation in pregnancy, and it'll just be a brief review. I think this is the one situation that none of us want to be involved in, and I definitely don't want to be involved in the next how many of the weeks I have. But it can occur, and if you look at this, you're going to do CPR and actually do what we'll talk about, the lateral tilt later. But for resuscitation in pregnancy, most common causes of, you should know, of pregnancy-related death are cardiovascular, cardiomyopathy, hemorrhage, infections, sepsis, hypertensive disorders, and thrombotic PEs. But despite the fact that seeing a pregnant patient in cardiac arrest is scary, you focus on the mother. Best maternal care will provide the best fetal care. Volume resuscitation is very important. You have to accommodate for the increase in blood and plasma volume that develops during pregnancy. So you have to actually give volume resuscitation that increase by 50% than what's required by a non-pregnant patient. And you have to do that. It's best to do that, of course, with rapid infusion of saline, because using vasopressors, especially in pregnancy, even though if it's indicated, you have every right to do it. Uterine arteries are maximally dilated and blood flow is pressure dependent. So give them fluids first, then do vasopressors if needed. In resuscitation, you're going to do the left lateral tilt. And that's more if you understand with the uterus and how it could press on the IVC. You're going to do compressions like I was showing in the picture earlier while the patient's in this in this position. And this graph is just to show changes in maternal heart rate, which with the supine or lateral patient. And you can see if the patient, I'm sorry if it's difficult to see, the patient in the lateral position has an increased stroke volume and increased cardiac output.
Oh, did they make changes to that though with the new 2015?
Oh, I didn't know. I apologize if I'm not up to date. Did they?
So in the most recent AHA, just for recertification purposes, I think too, I think that's the new,
What does it say?
that you don't do the
Lateral.
lateral.
You just do.
In
You just do
2015?
compression.
Mine will expire in December, so I'll be up to date in December 2016. Okay?
So, I mean, I'll try to confirm it.
No, it's important to bring up. So, medications used during resuscitation and just considerations in pregnancy. I know it's, again, another difficult slide to read, but I just want to point out that all the typical drugs that you would use in a non-pregnant patient during resuscitation can be utilized in the resuscitation of a pregnant patient. Just one area to be concerned of is amiodarone. Don't use it. If you could avoid amiodarone, avoid it, but everything else, save the mother, okay? Save the mother, you'll save the baby. And sometimes, yes, I think maybe later on in this block you'll get the perimortem delivery. I'm not touching that one. But you'll get into more details of how to do that. So again, just when you see that patient with the elevated blood pressure and in the second half of pregnancy, consider preeclampsia, eclampsia, and HELP. Vaginal bleeding, placenta eruption, placenta previa, shortness of breath or chest discomforts, peripartum, and in resuscitation of pregnancy, mother comes first. Okay? That's it.